all of us have incredible jobs and responsibilities that we're asked of. And, we have so many things we have to get done in a day. And I think residents in particular, right, are so busy. But I think it's very easy to lose track of the fact that there's a person laying in that bed or standing in that bathroom that sometimes you need to treat as a human. And imagine how you'd feel if you were in their position. And I always say to the residents, imagine that was your mom laying in there, or your grandmother, or your child. What would you do? Right? Would you stick somebody 22 times for that A-line if that was your son or your mom? Or would you put some lidocaine in that wrist and do it differently? Or would you come back and check the epidural later? And more than a few times, we've had experiences like that where we're just baffled that, they know us personally, but yet they still have no problem treating us like we're just a job to be done.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm your other host, Dr. Cyrus Askin.
So Cyrus, man, what are we going to talk about this week?
Well, on this week's episode, we're going to talk about the experience of being critically ill. And specifically, we're going to see what we can learn from that experience and how we can take those lessons and maybe provide more compassionate and overall better care.
Excellent description. Well said. One of the things that we set out to do when we made this podcast was to focus not just on the experience of caring for people with critical illness, but also to understand the patient's perspective on that illness. And we are very fortunate today to be joined by two guests who have a unique perspective on this to share. Two guests who are both intensivists and have been ICU patients themselves.
That's right, Nick. And without further ado, our first guest who's new to the pod is Dr. Alin Gragossian. She completed a residency program in emergency medicine at Drexel University and a fellowship in critical care medicine at the Mount Sinai Hospital in New York City. In 2019, Dr. Gragossian was admitted to the ICU with heart failure and ultimately underwent an urgent heart transplant herself because of familial dilated cardiomyopathy. After overcoming this tremendous, unexpected development in her life, Dr. Gragossian has gone on to be an intensivist and physician leader throughout acclaimed Medical and the associate medical director at DN West, an organ procurement organization in California. Dr. Gragossian was the chair of the American Society of Transplantation's Transplant Community Advisory Council, and we're very fortunate to have her with us today.
And along with Dr. Gragossian, we've got returning to the show, Dr. Paul Wischmeyer, who's an anesthesiologist, intensivist, and perioperative and nutrition physician, who's a tenured professor of anesthesiology and surgery at Duke University. He also serves as the associate vice chair for clinical research in the Department of Anesthesiology. He's the director of the nutrition team at Duke. And finally, he's the founder and director of the Duke Clinical Nutrition Fellowship. His clinical and research focus is on helping patients prepare for and recover from critical illness and surgery. He came on the pod back in episode 21, listeners will recall, and he taught us a ton about nutrition in people with critical illness. Listeners may also recall that Dr. Wischmeyer has a long relationship with the healthcare system following a long and complicated hospitalization, or really series of hospitalizations, for ulcerative colitis back when he was a high schooler with Olympic soccer aspirations.
So, this episode has been a long time in the making, guys, and we're so excited to have these phenomenal guests with us who also happen to be physician leaders and of course, they're patients. They were and continue to be. And so they're here. They're going to share their stories with us, and hopefully we're going to learn a thing or two about how to be better clinicians and be better bedside humanists. Nick and I are really honored to bring this to you guys, this episode, Beneath the Drape, Intensivists as ICU Patients.
Alin, welcome to Critical Care Time, and Paul, welcome back. I can't wait to talk with you guys. Maybe before we do anything else, you should just introduce yourselves. Alin, do you want to go first, and then Paul maybe
Sure.
afterwards?
First of all, thank you so much for having me on the show. I know both of you guys peripherally. I've talked to Nick a couple of times, and so it's an honor to be here. And I'm obviously also very excited to be here with Paul, who is like internet famous. His videos go viral all the time, and he's amazing in so many ways. So I'm excited to be here. But briefly, you guys did a great job in explaining what I am. I'm an intensivist. I do mostly telemedicine through a company called acclaimed Medical, and I'm also associate medical director of Donor Network West, which is the OPO here in Northern California. Most of my work, though, is focused not only on clinical medicine, but also patient advocacy through all the different organizations that I either volunteer at or do consulting work for. So it's been amazing being on this journey as a patient physician.
That's a great summary. And Paul, do you want to give sort of your brief bullet?
Sure. So as you may have heard in the introduction, my name is Paul Wischmeyer, and I'm a professor of anesthesiology and surgery at Duke. My practice is focused entirely on critical care and in perioperative medicine. I don't actually practice in the operating room. I just do critical care. And then I run the nutrition service for Duke. And probably 60 or 70% of my time is in research with the NIH and the Department of Defense on nutrition and exercise techniques to help people prepare and recover from critical illness and from surgery. And a lot of my research interest and in fact, my entire passion for being in medicine, it stems from my illness as a child, as I'm sure we'll talk about. And a lot of my research is into things that I do every day and have done every day through the many, many hospitalizations and ICU stays that I've experienced, and sort of things that I have found help me recover. I found ways to study and try to help others do the same. And it's the entirety of why I'm in medicine.
So it's an amazing story of, how you became the physician that you are. I want to get into that, but actually first, Alin, do you want to tell us your story of how you became a patient in the ICU?
My story is a little bit different from Paul's. Paul had chronic health issues and ended up in the ICU as a high school student and then went on to medical school. I like to tell people that because people assume that, people think that I became an intensivist because of everything that I've gone through, but it's actually the opposite. I had been in my final year of residency, and as you guys know, you apply to fellowships during, I think it was like November, December is when I matched into my critical care fellowship. Perfectly normal, healthy 30-year-old, had been to a doctor maybe a couple times in my life, athletic, ate well, never had any issues, but I started having this cough that wasn't going away. And then, looking back with hindsight, bias, I also was very fatigued and little things here and there, but who's not during an emergency medicine residency? So I didn't think much of it. Over the course of maybe a few weeks, I want to say 3, 4, 5 weeks, everything got a lot worse. And I remember I was actually the resident in the ICU this one particular night in December of 2018. And I used to, of course, when I was a resident on 24-hour call in the ICU, because I wouldn't have time to work out, I would use the stairs instead of the elevator to go up to codes as needed during the night. But that particular night, a couple things were off. And one of them was that I couldn't go up and down these stairs. I was taking the elevator to go just one floor up. And then one of my attendings had noticed that I was really short of breath when I was trying to present a patient to her. That was also kind of a red flag. Following day, I went home. I felt a lot worse. And, as they say, young people, when they decompensate pretty quickly. So basically, I went back to the emergency room because I was so short of breath. And at that time, I don't remember, they did some tests. They thought maybe I had a pneumonia because I had bilateral infiltrates on my x-ray, but nobody was thinking heart failure with an EF of 5% in somebody who's otherwise healthy. I got admitted to the floor to get more of a workup done. They were thinking possibly pneumonia, possibly something else, but something is definitely off with her. And eventually, I don't remember much of that night, but I had to get resuscitated. I got resuscitated. I was intubated, taken to the ICU. And later on, I find out that they basically almost called a code on me. There was a possibility of having a PEA arrest. In my opinion, now that I'm an intensivist, I'm like, well, maybe they just couldn't feel a pulse, but I had a map of 20, right? I was trying to justify exactly
it
what
was
happened.
pseudo PEA.
That's right. Yeah.
Exactly. And then, they took me to cath lab, and then eventually within a couple days, I woke up, I was extubated, and they told me that I had heart failure with an EF of 5%. Obviously in that moment, it was biventricular failure. They couldn't put an impella in. There was all these things going on, eventually got transferred to Penn. This all happened in a period of about 3 weeks of my life. So I had the diagnosis eventually transferred to Penn Medicine. And then the only thing that could have been done was a heart transplant. So I got a heart transplant. I was discharged home within all of this going on within 3 to 4 weeks of my life. Went back home and was trying to figure out how I can still go back to residency. Like that was my only thing on my mind, was like, how do I finish residency with a heart transplant? So it was all very sudden. But I took about 6 months off, went back to my residency, finished that. I actually ended up doing my critical care fellowship, which I had I'd matched into just 2 weeks before all this happened. So it was crazy that it had been something that ended up happening to me right at that same time. So that's kind of my quick story. We later found out it was due to familial cardiomyopathy, but we can get into that in a little bit.
My goodness, Alin, yes, that's a whirlwind of a journey that you went through in a short period of time, and I know you're still continuing on that journey in many different ways. And as you alluded to, we're going to get into that. Paul, I know in our previous discussion, you sort of talked a little bit about your story, but I was hoping for our audience you could maybe recap, kind of as Alin did, some of the highlights or the lowlights, if you will, depending on how you want to look at it for the folks that are listening today.
Yeah, thanks, Cyrus. I mean, that's an incredible story. I can't imagine what that would be like to be in your training and have that happen. My story, like Alin mentioned, is a little different. It goes back to when I was a child, and in my childhood, I had never thought about medicine. I'd never seen a hospital. I'd never been inside of a hospital. And then when I was 15, I was a freshman in high school. Like you mentioned, my dream was to be an Olympic soccer goalie. I played sports pretty much every day. It was over the winter. It was getting close to Christmas break, and I was playing basketball for my high school team, and I got strep throat. And I took an antibiotic, took erythromycin, and as everybody knows, erythromycin can upset your stomach. And I got an upset stomach and ended up with diarrhea. And I ended up in the bathroom 20 and 30 times a day, and then blood started to appear. And so it seemed to be more than just the typical antibiotic related kinds of things. And I was brought in to see a doctor who said, well, we need to do a number of tests on you. And I had no idea what that meant. And then began to be scheduled and undergo colonoscopies and endoscopies and barium enemas. This is all long before any of those things were things people sedated for. And I think it was at that point that I realized doctors were not nice people. In fact, I wasn't even sure they knew I was a person. I felt like that they had no idea there was a live suffering child at the end of their procedural scopes or at the end of their procedures. And I really was just a job to be done. And me being in pain or uncomfortable just inconvenienced them and made their life more difficult. And I think I began to realize that hospitals were very unpleasant places. And after those tests, I came in to see the physician, and he said, well, we're going to need to admit you to the hospital, and we're going to not let you eat anything for the next 6 weeks. And I'm like, the hell you are? I'm going to have a basketball game next week. There's no way that's happening. And he said, no, we're going to do this, and we're going to put an IV in you, and we're going to feed you through an IV for the next 6 weeks, and this is what's going to happen. And then within about an hour of that, I discovered what it meant to be a hard IV stick, and went through stick after stick after stick, and nurses sticking me, being annoyed that it was harder than it should have been, that somehow me moving was making their job harder, and the fact that I was in pain was totally irrelevant. This was a simple procedure, and why was I complaining? And again, I began to realize, gosh, these are not nice people, and this is not a pleasant way to live life. And so I was bleeding quite a bit. My hemoglobin was 3 at that point, and I could feel my foot beating in my heart beating in my foot. And through the next few weeks, I ended up getting 40 units of blood over about 2 weeks, and ultimately was transferred from a small community hospital to the University of Chicago, where again I spent about 3 months on TPN. And then ultimately, I won't forget it. I just started eating again. They just let me eat. And I remember I ate about 18 bowls of broth and actually put on about 20 pounds of water weight. I still have stretch marks to this day because of this combination of steroids and a lot of salt. And somebody came in, and I thought it was another person coming to tell me I couldn't eat again. But he came in, and during the day, I'd gotten a fever, and my abdomen had gotten kind of firm and a little more painful. And he shook me. I remember he shook me in the bed, and it hurt a lot. And then he said, you're going to have surgery tomorrow. You're not going to see tomorrow night, as if I would refuse. And he ultimately, I said, gosh, can we do it now? I'm like, I'm done with this. I don't want to live like this. And ultimately had surgery. Basically, he said my colon crumbled like a dry leaf when he took it out. Got quite septic afterwards, as you might imagine, with peritonitis. Was in the ICU at that point. And then, of course, they tell you when you have ulcerative colitis, the great news is you're cured. as soon as we take your colon out, you're going to be cured and you'll never be sick again. And they also said, well, you're going to have an ostomy for a while, but you're going to be the first child at the University of Chicago to have an illegal pouch done, this pouch procedure they could do where they make a pouch out of your small bowel. And I had that done about 8 months later. And unfortunately, it took 14 hours because I was a male with a small pelvis and a short mesentery. And immediately it caused problems and strictured. And over the next 5 years, it fistulized and leaked. And I was incontinent essentially for the next 5 years, all the way till I was a junior in college. Luckily, I went to the Mayo Clinic, started doing research with a colorectal surgeon who scoped my pouch and said, your pouch is not functional anymore. You have a fistula. That's why you're incontinent. And I said, I can't deal with this anymore. Just put an ostomy back. And so the surgeon I was doing research with ultimately put my ostomy back. And at this point, the surgery is starting to mount. And the other thing they don't tell you is once you've had a lot of abdominal surgeries, you have bowel obstructions. And there's a lot of things you shouldn't eat, but no one tells you shouldn't eat them. Things like mushroom and corn and nuts and apples. Well, that summer up at Mayo, I ate an apple one day and lost 40 centimeters of small bowel to the apple. And then through my life, about every 6, 7, 8 years, I would have 3 or 4 more surgeries for bowel obstructions. I would probably have 2 to 3 admissions a year with bowel obstructions, but I was able to clear most of them just without any fluids in time. Ultimately leading to 2014 when I had quite a few surgeries, and now I'm working at the University of Colorado as an anesthesiologist, and unfortunately ate some quinoa at a wedding and never eat quinoa if you've had bowel surgery. And I decided we would fly all the way back to Colorado because I wanted to control who cared for me. And we showed up in the ER. I'd had the bowel obstruction for about 18 hours at this point. My lactate was 10. They said, you have ischemic bowel and we need to rush you back. And the person that came to see me actually was a resident's new surgeon who I trained as a resident. She'd been out for about a month. And I'm like, Maria, yeah, I love you, but you are not operating on me. I said, so go get someone older than you and older than me. And there was an old-time cancer surgeon who took me and cleaned the adhesions out of my bowel. But they left a mass of adhesions because they thought I'd be too short gut and I'd be on TPN the rest of my life. Well, unfortunately, that continued to cause obstructions. I was in the hospital for about a month, then lost 20 kilos of weight. Began to realize that maybe that was just the inevitable part of being critically ill. I was in the ICU with open abdomen for a period of time after that surgery. And so in 2022, sort of to get to now, these bowel obstructions began to happen even when I was eating things I thought were safe. We were in Hawaii and I was surfing with my wife and I ate some like a milkshake and I got a bowel obstruction. And I began to realize I can't live this way. And every time I got a bowel obstruction, actually my ureter was encased in my bowel, and I would also get hydronephrosis and go into kidney failure. And so I realized that this is going to take my life if I don't do something. And so luckily at Duke, we have this wonderful bowel transplant surgeon who works on people like me every day. And one of the reasons I work here is her, Deb Sudan. And I said, Deb, I need this fixed. And she's like, you may be short gut the rest of your life. You only have 150 centimeters now. And if I take more, TPN may be your lot in life. And so she took me, did about a 14-hour operation. I was in my SICU afterwards, doing pretty well. And then the third night, woke up with a fever and stool pouring from my incision. And through a series of a couple surgeries, she tried to fix it and she couldn't. She's like, you have a GI fistula and I can't fix it. And, at that point, all of us as ICU doctors who cared for fistula patients, I began to realize, gosh, maybe I'm not going to live through this. And maybe I'm not going to see my kids grow up. And maybe this is going to be the end. And at least I tried to take a chance to get it fixed. Thankfully, went on TPN, went home on TPN, and 3 or 4 months later, the fistula closed. And that was quite an interesting ICU stay because I was being cared for by people I worked with in my own ICU with my own nurses, my own residents, my own respiratory therapists. I was intubated for a period of time, and I can remember waking up and seeing people I knew, and it was quite a unique experience to be cared for by your own caregivers. But thankfully, months later, my fistula closed, and I was able to recover. And I'm pretty sure I have 140 centimeters of bowel now because she had to take that 20 centimeter portion out. But through really aggressive hydration and a lot of loperamide, I get by okay. I feel really lucky to be where I am, and it's ultimately why I went into medicine. I think I went into medicine because I felt like I wanted to teach doctors to be better caregivers, and that healthcare has the word care in it for a reason, and it should be the center of what we do. And I think that was the motivation. It's motivation, I think, for most of what I do.
Well, Paul, thank you for recapping that, and I've heard elements of that story before, and I'm sure Nick agrees, and it's still just as
it hits just as hard hearing it again. Yeah, what a traumatic experience.
heart-wrenching. And yeah, so I think we certainly want to delve into both of your experiences during the course of our episode here, and get into the nuts and bolts to an extent. So I guess I'll start with you, Alin. When you started to manifest the symptoms of heart failure, as we've kind of already alluded to, in contrast to Paul, you were already a physician, you were already practicing, you had these great aspirations, everything that you had planned to do going forward. How do you think that your training and your experience as an early career physician, but a physician nonetheless, contributed to your experience as an ICU patient, as a surgical patient?
That's a great question. I was an ER resident. So, I knew enough, but I didn't know the intricacies of advanced heart failure, not even half as much as I did. Again, I did a critical care fellowship, and I focused primarily on cardiac. So I feel like even now I'm still there's still a lot that I don't know. I did know that, if somebody has a heart transplant, they're going to get admitted. That was to the extent of my emergency medicine training at that time. So I knew it was serious, but I feel like I didn't fully comprehend how sick I was. People kept assuming that I knew, how sick I was, but also all these things, what my SVR is today. I'd be like, I don't, and a lot of times there's different types of patients, and I tend to be the one, and people think this is interesting, that even as a physician, I'd rather, if I don't need to know, just don't tell me. I'll look at the stuff myself. You don't need to explain every little thing, which is, usually most ICU patients want to know every little detail of everything, especially transplant recipients. So I feel like at that time, I don't remember a lot of it, but I do remember understanding that I was sick, not really understanding the gravity of the situation. It happened that Dr. Greenwood, he's an emergency medicine, critical care medicine specialist at Penn, happened to be my physician. And he was someone that I had looked up to as someone who was emergency medicine going into critical care. So it was really cool meeting him. And I feel like everybody that I met there, they were trying to educate me while I was an ICU patient. So that was nice. Again, I feel like it helped me to an extent, and probably helped me more than I think it did, because there are certain things that I feel like didn't scare me as much as it would have scared someone who hadn't gone to medical school. But at the same time, I feel like I didn't have extensive knowledge of advanced heart failure. I even remember when they wanted to transfer me initially for potential advanced heart failure therapies, in my head, I was like, what is LASIK? A LASIK strip? How advanced is this heart? I didn't even fully comprehend that until after I got there. And my cardiac index, even on milrinone, had been 1.2, something ridiculous. So, I was barely, looking back and looking at my numbers now, I'm like, oh my God, I'm kind of glad that I didn't fully comprehend everything. But to an extent, whatever I did understand helped me. And that was probably, for someone like me, was really good.
There are two things I wanted to follow up on. That last point you made, that's me. I would be like, oh my God, I've seen the worst of the worst and the sickest of the sick. That's what I'm in for. I would be terrified. I feel like I would just be paralyzed because of that knowledge. But it's an interesting paradigm that you bring up, because while you were a physician, you were a trainee in emergency medicine. So it's you almost knew enough to be able to maybe ask some intelligent questions, but not enough to freak yourself out, maybe as much as I would right now, or you would right now.
Exactly. Even in the CTICU, when I was taking care of patients, I was like, oh my God, my numbers were way worse than this person. That was I even remember thinking oh my God, how did I make it? So there were plenty of times, years after, where I was like, ooh, that was pretty crazy what I went through. So I think it was just enough knowledge, but not too much, and it helped.
The one other question I had before I hand it off to Nick, because I know Nick's got a lot he wants to delve into, but you mentioned that there were times when assumptions were actually made. So kind of the reverse. There were assumptions that were made based on, oh, she's a doctor, so we can talk to her like she's a doctor. She knows exactly what we're talking about when we're discussing, CI, CO, SVR, et cetera, et cetera. Were there times when that had maybe a negative psychological impact? Because I feel like I'd be like, oh man, they're talking over me, or I don't know. I feel like those assumptions would potentially make me feel bad. Maybe it's just my own inadequacies, and you're probably, don't have those in the sense that I do. But
No, I do. I understand what you're asking. There were specific times where I was asking. I was just very upfront. Like I'd be like, I don't know what you're saying. I don't know what that means. But even now it happens sometimes. Like I'll bring it up to my transplant. I'll be like, hey, what do you think of starting Jardiance to like decrease the chance of CKD? Like it's not something. It's something that's like being studied. But like he's like, that's a good idea. What else do you want to do? And I'm like, oh wait, no, that's the only thing I know. I don't know anything else. So at times but I am pretty honest and open about what I do understand and what I think I'm comfortable managing or asking questions about. Otherwise, I'm usually like, it's all up to you guys. Like whatever you think is best for me, I'll try.
Yeah, I think that's really interesting. I mean, I think that, sometimes when you have a physician as a patient, it's kind of like we have two speeds for kind of interacting. One is like, assume you don't know things. I'm going to explain everything. And the other is assume that we all know the exact same stuff, and I'm just going to give you numbers. And there really is like a lot in between those two, right?
Mm-hmm.
I mean, it's really interesting because like it's like you want to be respectful to somebody's knowledge and education and experience, but yeah, you got to be really careful not to assume that like these numbers that I, think in terms of are going to mean something to somebody else. I think that's a very important point, I think.
Exactly. And I think a lot of people tell me like, people will say like, I'm a doctor, but I never tell my doctors that I'm a doctor. I'm like, ooh, like I always tell them because there's been plenty. Like I remember one time I was taking care of someone and, I was like, oh, today we're going to check your blood. Like I was talking the way I would with a person who's not a physician. We're going to check your blood work today. We're going to get a picture of your chest. And then like 5 days later, I find out he's like a pulmonary critical care doctor. Like, and so he's like, oh, I didn't want to tell you. I'm like, okay, well, that made it a lot more embarrassing. So you could have just told me and I could have, talked to you about like questions that you actually had. So I do tell people, but I also tell them like, hey, I don't, so you can still tell me whatever you were going to tell me. I'm not going to take control of certain things.
It's kind of like some weird riff on Undercover Boss. It's like, gotcha.
It's so embarrassing. Yeah, it's like telling him I was taking a picture of his like lungs.
Yeah, I think it's funny. I never know what to do like when I'm like with my kids at the doctor or something, like whether to sort of play cards close to chest or just like be out with it. So Paul, it occurs to me that your perspective of this is almost the mirror image, right? So in contrast to Alin, who kind of had medical knowledge and then experienced illness, you had the opposite journey. You experienced illness and then you acquired medical knowledge. How do you think like the experiences that you had were like kind of shaped your medical education? And how much of your experience in critical care, like learning critical care, was informed by what you had gone through as a patient?
I think a lot. I think what sealed the deal for me that made me realize as a 15-year-old that I had to go into medicine was back in the 80s, they thought ulcerative colitis was a psychological disease or stress related. And I remember the child psychologist coming in and asking my parents and I, what did you do to him that's led to him being so stressed out he got this disease? Did you spank him too much? Did he have a hard childhood? And I remember my mom thinking, honestly, she caused my illness. And I remember her coming to tears because, we're at the University of Chicago with all these brilliant physicians, the bastion of the smart people work there. And they really made her feel like she caused my disease. And I will never forget that. And she has never lived that down to this day. She still, in large part, feels responsible that something she did as a parent caused me to have this life-threatening disease. And I'll never, I think, lose the anger I felt about that since then. And it made me realize I'm going to go into medicine and I'm going to teach, hopefully, people to communicate better. And I'm going to go into research and try to prove some of these things that we tell people aren't true. Because I think what it taught me quickly is the things you say as a physician mean a lot. We take your word like the word of God, and it affects people forever. And you need to be really thoughtful about how you choose your words. And the other thing that was very common for them to do, and my parents told me later, is they would always tell my parents, he's really sick right now. We were going to fly him from the one hospital to the other, but we didn't want to alarm him. I don't want you to share with him how sick he is because it'll stress him out. When they would go outside the door and close the door, it wasn't hard for me to know when I was getting so much blood that I couldn't get out of bed because I was too anemic. Even a 15-year-old knows something really is wrong. And it made me even think the worst because they're outside closing the door, like I'm probably going to die tomorrow and they just don't want to tell me. And so I have to tell you one thing that I have sworn by and lived by. I never close a patient's door outside the room, not in the ICU, not on the floor, not anywhere, not ever. And if the residents do it, I immediately open it and say, I don't ever want to see you do that again. Because inevitably when you close the door, the patient is sure you're saying something terrible. And so I think quickly I began to realize that communication really mattered and that most people don't really share a lot with our patients. I mean, there's exceptions to that, of course, but I think that was really a huge motivation for me because even at 15, it wasn't subtle what was happening and they never wanted to tell me. I mean, the people I was closest to were the medical students and the nurses because at least they would talk to me. And I think the other piece that comes out of that that's very relevant for us as intensive care providers is, procedures are an incredible stress to us. And I remember I mentioned IVs, that's one stress, but I remember the first central line I ever had put in when they were going to start TPN. And I'm under the drape and the GI fellow was sticking around in my chest for about 40 minutes. And finally, he's not getting it. And when we do a central line right, we can see the whole room. But when a patient's getting a central line, and you might remember this, all you see is the blue drape. Back then, the drapes weren't clear. And you can't see anything. There's this giant needle coming at your neck, right? You knew that, I'm sure. Even I knew that at 15. And I remember asking about 40 minutes in, I'm like, isn't my lung really close to where that needle is? And he's like, yeah, actually it is. Maybe we should come back and do this tomorrow and I'll get someone else. But it was it's terrifying to be under that drape. And so I am a very aggressive procedural sedator. I use ketamine a lot. I sedate for A lines, I sedate for central lines, I sedate for G-tube placements sometimes. They're incredibly uncomfortable and painful to have placed. And I think they're really just torture devices that don't do any good. But yeah, so I think it definitely affects everything I do every day. Like I don't prescribe oxycodone to anyone. And that was because it was the one drug that I couldn't get off. I got in every opiate in the world. I spent 3 months in rehab trying to get off that one. It almost killed me.
Oh, geez.
So it's and I learned in rehab quickly that that's the only drug a heroin abuser will use because it feels just like heroin. And it isn't the high is better, the withdrawal is infinitely worse. And I think people think all opiates are the same, and they're not. Nobody was shooting up pharmacies to get morphine. The withdrawal from oxy is outrageous, and I couldn't get off by myself. It was like being possessed by a demon. And so I tell that story. I that's one of the things I mean every week I'm in the ICU to teach them. I don't ever want you seeing prescribing this drug for knee surgeries and appendectomies and every other thing because it just is easy to do.
I want to double click on a couple of those important points you just made there, Paul. First off, I mean, it seems like, uncertainty or not knowing is far worse than knowing, right? That like, I think I heard you say a couple times that just like, you're going to make up a worse explanation for why the door is closed than the reason why the door is closed. And so, just remembering that like the void of information leads people to imagine really scary things. I think that's a really powerful point. The second point, I want to learn more about the experience of being on the receiving side of pain management and like what, how that chronic illness role of opioids like affected you. Can you tell us a little more about that?
Yeah, I'm going to start with the opioid one first because I think it's, if I have a few soapbox issues, that's one of them. I think there was a time when I think we overdid it with the pain meds, and I think the oxycodone sort of beginning of that pandemic. I remember when I was a patient in 2003, I had some surgeries and I had bowel obstructions, and I had residents that worked for me in the ICU seeing me and writing me prescriptions. They'd give me 300 oxys to go home with, right? And I was on 500 milligrams a day by the time I finished that series of surgeries. But now, of course, with that, it's swung the other way. And where a standard PCA used to be 0.4 Q8, now it's 0.2 Q10, and everybody seems to think that's enough for everyone. And it's not. When I was in the hospital just a year and a half, 2 years ago, I was on a milligram Q10 minutes of Dilaudid on the floor with no pulse ox, right? Because I've gotten opiates since I was a kid all my life, right? I remember the first time I got Demerol, the birds sang, the flowers bloomed, I love my mom and everybody else. I mean, it's life changing and it's anxiety releasing. And of course, those are the issues that can get us in trouble with it. But I think it swung too far. And, I think I've definitely experienced both sides of that. That said, the other piece of it is nobody tells our patients that if you've been on opiates for a long time, you're going to withdraw from them and it's miserable and it takes a long time. When I was 15, I went through withdrawal and I ended up coming back to the hospital because I was so anxious. My parents didn't know what to do with me. I was really just withdrawing from opiates. Got put into a locked psych ward in the inner city of Chicago. I was the only kid in the psych ward. It was an adult unit. It was terrifying because I thought I had some sort of anxiety disorder. I slept under a ping pong table in the rec room the first 2 nights. I was terrified of the patients. It was the most traumatic 3 days of my life. Was locked in there for 2 weeks, all because I was drawing from opiates. There was nothing else wrong with me, but no one recognized it. And I don't think we help our patients think through, how are you going to get off these drugs, right? Because now, of course, my wife and I know exactly what to do. You take Ultrium and you wean the Ultrium, and Ultrium is now published. It's the best withdrawal method there is. And I learned that in rehab, right? I would have never learned it otherwise. It's now published in JAMA and things, but it wasn't then. And I tried working with my chair in my department to get off in 2003. And it felt like every day I was possessed by a demon. And every day I woke up and swore I wasn't going to use them. And every day I had to use them. Because they called me back to work 3 weeks after on 400 milligrams of oxy a day and said, did you come back and work? We need a liver transplant anesthesiologist. He's like, do you think you can work? I said, I think I can. I said, can you help me get off these drugs? He said, I think I can. I mean, it wasn't his expertise either, but he couldn't. And finally he came to me and he said, Paul, you don't look good. And I wasn't good. And I finally admitted that. And I didn't know they were going to send me to rehab the next day for months. But that's what happens. But the great thing is physician health programs, you don't lose your license. If you do what they tell you to do, you get better and you keep your job. And I think a lot of physicians are afraid to talk about that. And they definitely aren't talking to their patients about it. And so I think that's where we need to support each other as physicians, but also support our patients. And there are ways to do this so we don't have to suffer.
Yeah, and I think you just made the point that I was going to ask you about, which is the importance of physician health programs, and that there are processes in place that can make this not a career-ending event, whereas addiction is often a career-ending event.
It's the number one cause of death in anesthesiologists under 40.
Wow.
And that's often because their colleagues see it and are afraid to say anything because they're afraid they'll lose their job, which isn't true, of course. But yes, and I'm one of the ones who I think is an incredible athlete. They saved my life. I was never going to get off those drugs on my own, ever. And I was practicing, I did a clinical pharmacology fellowship. I knew more than anyone should know about opiates at that point, right? But it didn't matter. It's like being possessed by a demon and you need help, and our colleagues need help. And that's why if you see someone you think needs help, say something.
Alin, I'd like to ask you a little bit more about your experience in the ICU, after Paul has shared some really traumatic insights, both from his younger years and then even more recently, which I just think is crazy. So in terms of your own experience, I know you've been in and out of the hospital yourself. Maybe you could share something that you found that was just kind of unexpected or surprising to you earlier in the course, and then even maybe something more recently, something that you just don't really, that maybe our listeners wouldn't expect as it relates to the way that you're cared for, perhaps even nowadays.
Sure. First of all, Paul, thanks for sharing all that. I will say that I don't know if things used to be a lot different, like, in the 80s, 90s, early 2000s, as far as pain management goes. For me, as someone who recently in the last 5 years, got heart transplant surgery, I've had AVN in my hips because of the steroids. So I actually got both my hips replaced during fellowship. Like, the pain management that I had was not as, they gave me just enough medications and told me not to, so I do think, hopefully, and I tend to be positive sometimes, like, I do think that things have shifted in the right direction, at least from my experiences. So that's one thing that I'll say, but it doesn't mean that doesn't exist. As far as like experience that I went through that I feel like people should know more about, Paul touched on it earlier as far as communication goes. I do think we're better now. I do think that like our generation of physicians, we tend to be more open. I mean, even now, like, patients could see all their test results pretty much immediately, right? Things are just a little bit different. But I will say that, I'm coming from my parents are immigrants. My dad speaks English. My mom doesn't really speak English. They're not in medicine at all. They were so confused most of the time when I was in the ICU because they didn't understand, like, for example, an intensivist would come in and say, she's fine. Right. And so like the intensivist's goal is just to keep me alive. So yeah, sure. My vitals are stable and I'm fine. But the cardiologist would come in and say like, she still needs a heart transplant. And then surgery would come in and, I had lost a lot of weight just because of the heart failure. Like I was a edematous, but they were trying to get my nutrition up in time for surgery. And I remember like, that's what they were focusing. My mom was like, why are they all saying different things? And like, why is the cardiologist so like negative? And they're not negative. It's just like the pre-heart transplant team is the one who's going to be focusing on whether or not, heart transplant. The surgeon is going to be focused on optimizing my clinical status for surgery. So I always tell people that one thing is to always not only introduce yourself, but also like why you're there. As an intensivist and emergency medicine physician, people never know what I do. They're like, oh, you're the person who is in between everybody else. Like what? So I try to explain that. And if anything, maybe make sure when you're talking to your patients that you talk to the team too. And so you guys are all kind of saying the same thing. So that's like one thing that I definitely continue to tell people. This is not only an outpatient setting, but also an inpatient setting. So always make sure that when you introduce yourself, make sure that the patient and their caregivers also know. Again, I'm a doctor. I'm sure they were like, she knows what's going on. My parents had no idea. I mean, no idea what was going on with me. So it was extra difficult.
Oh my gosh, yeah, I can imagine like a lot of, I've practiced in Texas now for quite a while, and a lot of my patients are Spanish speaking only, and so my Spanish is serviceable in most cases, but when it comes to a lot of these, what I would say are serious clinical decisions or certainly end of life discussions, those sorts of things, I make, no qualms about it. I grab, an official interpreter or use the translator phone or whatever to make sure that discussion is had with the highest fidelity possible, because that I can only imagine your mother in particular, like bearing witness to everything that's happening to her daughter and feeling clueless and feeling helpless as she's trying to like be your protector. That's just terrible to me.
Yeah, she's very superstitious, Persian mother. So she had brought in like garlic and like kept telling me I was like, Mom, it's not vampires. This is like cardiogenic shock. Like she just had a whole different like viewpoint of what was going on with me, which again, it doesn't mean that it's wrong, but just I always try to keep that in mind. Culturally, people are going to have different viewpoints of what they're going to see things differently. And they're going to, even when you talk to them, they might not be interpreting it the way that you mean for them to interpret. So
yeah, I think that's a great point. If I ever see garlic in a room, I'll understand it better now.
It's like, Mom,
I was going to say, I think another point that comes to mind here is that like, there's sort of like the blind man and the elephant thing here, where like when you have a bunch of different specialists who are all sort of weighing in and each sort of like opining about their particular organ, that like that can be very confusing for patients and families, right? Like things are going great, says the heart doctor. Things are going badly, says the kidney doctor. The intensivist says everything's stable. Like how do you interpret all that? And like
that's what they were saying. They were like, can't the cardiologist talk to the intensivist because he said everything's fine? And I was like, the fine is stable, which is not, it's not the same thing.
Right. And like sometimes, people read so much into trends too. I mean, especially people like you were mentioning, like people who have access to their records and their creatinine goes from like 3.6 to 3.5. And, like it's improving. I'm like, maybe, I mean, I'm not even sure that's like a significant change. Right.
Yeah.
And like, I think sometimes just like with so many things changing, so much complexity and so many people, it's very easy for us as physicians to see the trees instead of the forest. And I imagine that we like pass that confusion along to patients and families too.
Yeah, I will also say one thing. So my dad has cardiomyopathy. He had never really told me about it because they didn't want to scare me, which is also culturally like, yeah. So my dad, was diagnosed with this in his 30s. His dad had sudden cardiac death in his early 40s. So like, there's obviously, we ended up finding out it was a desmoplakin gene mutation. But my dad kept telling the doctors like, I'm on Coreg. I've been on Coreg for 20 years. Can't you just give her Coreg? And you can't give a beta blocker. And so even little things like that, like they would explain it to him like, no, we can't. And then they would explain like very, very complicated terms that my dad, like I was like, I'll just try to explain it to him. Like, we are past the stage of Coreg right now. This is something else that needs to be done. But yeah, so it's really important to not only know like culturally what the caregivers and the patients are thinking, but also just their level of understanding and what they're interpreting your explanations as.
So I think one thing that I've heard both of you talk about is the kind of experience of being cared for by your own colleagues, either people that you know very well, in Paul's case, people that you trained, or people maybe that you knew of a little bit more, like in Alin's case. I'm curious what that experience is, being treated by your own colleagues, and how that experience has changed the way you practice when you're the physician instead of the patient. Paul, do you want to answer this one first?
Yeah, I think, the line I always give the residents when I sort of talk about the experience of being on the other side of the curtain, I guess you'd say, or is always remember patients are people and not a job to be checked off a list. We're not a to-do list. We're not a checkbox. We're people. And I think one of the most poignant experiences I ever had was when I was in the hospital after surgery and after being in the ICU in 2003. As I mentioned, I have an ostomy, and there was one morning I was having a really difficult time with the new ostomy they had made. They weren't able to broke it. It was bleeding and it was pooping, and I'm in the bathroom and I'm naked, and I'm almost in tears already because I'm so frustrated with trying to change it and stop it from bleeding, and it's hurting. And the pain team comes in. So I have an epidural. That's, I think, one of the major advances, honestly, as a patient having abdominal surgery or any surgery, is I always have epidurals. And so the epidural team wants to do a quick check of my epidural site, my back. And there's 7 of them, right? And these are all people I know. These are people I've worked with for many, many years. So you've got a nurse practitioner, you've got medical students, you've got residents, and they come in and they see that I'm in the bathroom. And I said, I'm having a really hard time in the bathroom and I'm naked, and could you come back in a few minutes? Could you come back later? And they said, no, this will only take a second. And all 7 people come into a room of about 5 by 5 square while I'm naked and crying and stooling to check my back. And I was just paralyzed. It was the most dehumanizing, depersonalizing experience I'd ever had in my life. And thankfully, my wife walked in. My wife is an ICU physician assistant of many, many years. And she exploded on them and essentially scolded them like they were bad 2-year-old children and said, I don't ever want to see any of you in this room ever again. But it was just awful to me and for both of us. And we said after, this is how they treat people they know. I'd known these people for years. I'm a tenured professor in their department for many, many years. If this is how they treat the people they know, how do they treat the people they don't know? And how is this possible? And how often is this happening? And I think all of us have incredible jobs and responsibilities that we're asked of, and we have so many things we have to get done in a day. And I think residents in particular, right, are so busy. But I think it's very easy to lose track of the fact that there's a person laying in that bed or standing in that bathroom that sometimes you need to treat as a human. And imagine how you'd feel if you were in their position. And I always say to the residents, imagine that was your mom laying in there, or your grandmother, or your child. What would you do, right? Would you stick somebody 22 times for that A-line if that was your son or your mom? Or would you put some lidocaine in that wrist and do it differently? Or would you come back and check the epidural later? And more than a few times, we've had experiences like that where we're just baffled that, they know us personally, but yet they still have no problem treating us like we're just a job to be done.
Do you think it's harder to say no when it's somebody that you know?
Yeah, I think so. Not anymore. I don't think it is. I think my wife has taught me that. I'm nicer than she is when it comes to things like that. Thank God. She's the best caregiver, protector, and human I've ever known in my life. And I would have never survived doing this without her at this point, honestly. But it is hard because how hard their jobs are, and you want to accommodate. You understand they have a lot to do, but I don't feel that way anymore. Even other silly things like, have you ever thought about how vancomycin and Zosyn is dosed? So my last hospitalization, 2014, I was on vancomycin and Zosyn, and the way it's scheduled, right, Q6 and then Q12 or Q8. When I was in the ICU and on the floor, that it was scheduled at midnight for the Zosyn. And so the nurse would come in at midnight, wake me up and hang it because I got to do all the epic charting, and then I'll turn the lights on. And then it stops at 1, and at 1:15, she'd come in and hang the vancomycin, and that would run until 2:15. And so you're basically getting woken up all night. And so we finally said, change the dosing of our drugs so that I can at least sleep from 12 to 5. And we put a skull and crossbones on the door and said, nobody comes in the room from 12 to 5. Because otherwise I was never going to sleep. And I mean, the delirium that, especially this last hospitalization in the ICU I suffered, was tremendous. And that was a big part of it. And simple things like even how the intervals we dose our drugs at make an incredible impact on the delirium and quality of life that our patients see, and the ability to sleep and everything else in the hospital that they experience. And it seems so trivial. And they were so annoyed that we asked them to change the dosing intervals, but it was a trivial thing for them, and it was a huge change for us.
I completely agree with everything that you're saying. People ask me whether or not I'm okay with my colleagues treating me. I actually personally would rather have that. I just feel like, like, for example, in my fellowship, I had switched all my care from Penn to Mount Sinai. So I was a heart transplant recipient getting follow-up there. And then all my colleagues were, I had been hospitalized for my AVN. I had like colitis a couple times. And then I also had a PE. So anytime I was hospitalized in the ICU, like there was my own co-fellows, my attendings, and I found comfort in it, but there were plenty of people who would be like, I would go to NY, I would go somewhere else. I don't want anybody ever taking care of me. I found it like, at least if I feel sick or something during my shift, like they know me and they know that something might be off. But I agree with, doing the little things to help humanize our patients. I actually remember one time there was an ICU patient, a post-op patient of some sort, who was trying to eat, but so she had her plate from the cafeteria, but she had to use the commode. And so the nurse had put the commode next to her, and then, like the food was right there, right? And so what I did was I just like covered it and kind of put it to the side. And then the patient said something like, I could tell you've been a patient before or something, because like, that's not something that, like even the nurse was like, why are you doing that? I was like, well, she's using the commode. Like, why? So even little things like that are really important. But overall, as far as like colleagues taking care of me, all good with it.
It's so interesting, Alin, when you mentioned that, it's like all of a sudden you step into a hospital and it's like bizarro land. Like, in what world like would you bring your dinner tray into the bathroom with you at your house and start chowing down,
So
right?
true.
Like it's gross, it's weird. So, and yet in the hospital, it's like I actually was kind of waiting for the part where the nurse like brought the tray to the patient while they were, on the commode physically. Because that to me is like, oh yeah, it's like it just is the way it is. And it's like, it shouldn't be. Like, that's why are we okay with creating this like parallel bizarre universe that turns people into, like you said, Paul, like you guys, check boxes into like meat to be moved.
Right. So I also will say that like sometimes I'm like, it's a hospital, it's not going to be perfect, right? But there are little things like that we can fix.
Yes.
It's not a hotel. Like, things are going to not be perfect, and that's fine. But little things like making sure if the patient isn't unstable, let them sleep between 12 and 5, change the antibiotic dosing, make sure they're not, having bowel movements next to their food.
Yeah.
Like, these are little.
It's just, it's like,
I mean,
common
the
sense.
fact that the vancomycin is dosed, you ordered it at 3 a.m. doesn't mean that it should always be given at that time. Like, it's okay to retime meds. Like, there's a lot of things we do for no reason, and there's a lot of things that seem trivial to us, but are like really impactful. And it takes like 5 seconds to just change something like that.
Literally.
So, Alin, we've kind of touched on this a little bit, but I wanted to ask you maybe if you had any more stories to share, if you wanted to elaborate any further on this idea of how we approach procedures. Everyone on this recording is a proceduralist. And I know, Paul, you've talked about your approach to procedures now as a clinician patient, we'll say. But I'm curious, Alin, I think we tend to, I know I've done this before and now I feel like horrible about it, but tend to downplay like, oh, it's just a central line. I've done hundreds of these. It's no big deal. It's easy. I'll just throw it in, right? Or this A line, like I can do this A line in 15 seconds. It's going to be more troublesome for me to numb up the patient and cause them the pain of the lidocaine injection and then just put the darn thing in. So
It's not the same.
Right. Yeah. Clearly,
Right.
clearly it's not. So, I've heard this from colleagues before. I've had these thoughts before, not anymore, because I think I've learned from folks like you guys. But with that all being said, now that you're in a procedural subspecialty and you've had experiences like the ones you've described, how do you approach those instances with your patients, and how do you make sure that their personhood is prioritized over their patienthood, if you will?
I will say, and again, this is going to be the difference. I have a podcast with Kobe Salerno, who's a cardiologist with a heart transplant, but he had hypertrophic cardiomyopathy as a kid, and now he's a doctor. So I will say that because I was a doctor before I was a patient, I do have a little bit, I might have different perspectives than Paul, for example. So I do think that we need to adequately either sedate or give analgesia to patients who are going through specific procedures. As a heart transplant recipient, I was getting a right heart cath, which means a central line, pretty much once a week for like the first couple months of, like, I would go as an outpatient. So I got very used to it. And although it's painful, but I do think that you can give enough lidocaine. There are some patients who are going to require sedation for these things, and there are some who aren't. Like I remember I wanted to like go to my shift after one, and I was like, can we just don't sedate me? Like I want to work this afternoon. So I think it also depends on how comfortable that if it's their first time versus if they've done it a few times. But one thing that I tell people is like there's specific things that I remember from getting central line so often. One is like the sound of the blood dripping when you're trying to like hold down pressure. So like that's something that I get like chills from, because I just remember it's something, or like the sound of the wire going through. Like these are things that you don't think about as a proceduralist, that the patient like under the drape, like it's already hot and uncomfortable, and like all I could hear is this wire, and then I hear someone say, oh, and then like they put their hand on there, and then there's like blood dripping out and you could hear it. It's just weird. So I do feel like there comes a time for proper sedation, and we need to give it. It does depend on the patient as well. And I think being really, really liberal with the amount of lidocaine you use, but also keeping in mind that after the procedure, that area is going to hurt. And I think that's what we don't remember a lot of times. Like if you need to give a longer acting anesthetic, or if you want to maybe give them an extra medication afterwards to help with that pain that's after these arterial lines, central lines, chest tubes specifically, very, very painful. I had like 5 post-operatively, and I got a couple before my transplant. I remember like it wasn't so much the pain of the actual cannula going in, it was afterwards, like the soreness, and then I couldn't breathe, and it was those kinds of things. So I do think that there's specific things that we need to be better about, which I try to do, especially when I was a fellow doing all these procedures all the time. But I do think that if you voice that, like again, I will say, when people are doing procedures on me, they know I'm a physician, so it might be different. My experience might be different, but I try to ask for specific things, and I'm very vocal about what I need or what I don't need. And I appreciate when patients do the same.
So, Alin, the one thing that I'll just comment on really quickly is this. I say this a lot on the podcast. Every patient's an N of 1. And so, yes, we have all this great data to support our decision making, but just because Mr. Smith needed, hardly any lidocaine for the central line doesn't mean that Mrs. Johnson's not going to need a little bit of ketamine and a lot of lidocaine and this and that. And so I think that's a tremendously valuable point. Nick, I'm sorry, you were saying?
I was just going to kind of emphasize a point you made too, which is that sometimes as proceduralists, we think about like, how will this local or sedation help me do the procedure? And that's the wrong framing, right?
Amen.
It's not about, will it make my job easier? It's, will it make this person's experience of getting the procedure better? And remember that's not over when the procedure is over, right? Like if you could do an art line in 15 seconds, great. but they're going to have that outline for a lot longer than that. And
Yeah,
it's
it
probably
hurts.
going to smart. Yeah.
Mhm.
And like, I think that's a really important framing that like, we're not doing these things to make our time efficient. We're doing them to make somebody else's experience better.
I tell the residents there's no dose of opiates, there's enough.
Yeah.
Mm-hmm.
That's an excellent point, Paul. And I think, to Nick's point, I still struggle with this. When you have a laundry list of things to do as a clinician and you're trying to get things out and one after the other, and you're waiting on, you've got ED consults, you've got consults on the floor, you've got your own ICU, et cetera, et cetera. I'm only human. I'll be honest. There have certainly been times where I've been like, I just kind of need to get this done and move on. And it's, when you reflect on that, it's really, it can be really, really challenging to call yourself a good physician and yet have these experiences. It's just like trying to strike that balance between humanism and medicine and finding out that like you really can't be, I think, a great physician without being a humanist as well.
I agree with that, but I will also say that as a physician patient, there's been plenty of times that I've probably understood sometimes, they're probably just in a rush, right? Like I don't take it personally. So I feel like it's also helped me on both ends. There's plenty of times where I'm empathetic. In fact, I'm more empathetic towards physicians at times, like when I'm the patient, because I'm like, well, because a lot of patients will be like, the doctor only spent 10 minutes with me. And I'm like, well, that's because they probably only have 10 minutes because they have 100 other things. So there are times, and I'm not saying like it's okay to justify every physician's actions, but there are times where I use both experiences to empathize with both sides. And at the end of the day, we're all trying to do the same thing and we're all trying to help patients.
I think one of the keys there too is it's interesting, Alin, you sort of, you have a very good attitude towards it. I think I'm probably not the same kind of patient you are. I think I'm the patient they think is a little bit crazy. And, all of us have cared for these patients that we think are difficult and crazy. And they're inevitably people with chronic illnesses, right, who've been hospitalized a lot of times. And what I always tell the residents is I don't want to hear what you think of the patient until you've been the one laying in the bed, because I think the more times we're sick and the longer we've been patients, at least for me, the more anxious I am, because the more times I've seen things go wrong, or the more times I've suffered the complication they tell me only happens 1 in 1,000 times, or I've had the thing that wasn't supposed to happen. And so our anxiety is much, much higher. And so, these people what we label as difficult patients really are just probably people who've been a patient a long time and have been through a lot of bad outcomes and a lot of bad things, and just need your patience. And I hate I hate it on rounds when they lead with, this is one of those patients. They're a little crazy. They're anxious. They're this, they're that. I don't want to hear that from people. I'm like, you lay there and see how you'd feel, especially as a caregiver, as a medical person, because you know everything that can go wrong. And so I really try to get people to check sort of that, frequent flyer notion of patients and how difficult those frequent flyers are. I always remind them I'm one of those frequent flyers.
And also, what a self-fulfilling prophecy, right? I mean, if you frame somebody as difficult, like what is the...
Everyone thinks they are.
Yeah, exactly. Like, saying stuff like that is kind of profoundly unhelpful, like maybe if you're going to say something, say like, okay, there's a spouse who really wants to be informed about any change, even if it's a phone call in the middle of the night, like something that's like actionable, at least, not like, oh God, this family's so difficult.
Right. For sure. And I think that to take that a step further, what drives me even more crazy is the desire in the middle of the night on rounds, or if you're on call at night, if the patient's being difficult or is a little delirious, let's just slam with a bunch of Haldol and have a good night, not have to deal with them. I hear that on sign out all the time. And I always ask whenever I hear a resident say that, or a fellow, have you ever gotten Haldol? And they always look at me and say, well, no, of course not. And they say, well, I have. And I'll never forget it. I was 15 and I was in the ICU. And I told the surgery resident, I'm seeing deer and trees and I think I'm in the woods, and it was actually quite pleasant. And he said, oh, I can fix that. He's like, we have a medicine that'll take care of that. You won't feel that anymore. And so they that night they gave me Haldol. And minutes after getting it, I remember I felt like my room suddenly was bright light. And I suddenly started to feel like I was falling, and I felt through what felt like 4 glass floors. My body shattered on the ground at the bottom of my now 6-level hospital room. And my body went into a million little glass pieces, each had a tag on it. And I spent the next 4 hours walking up and down the stairs of my now multi-level room, putting my body back together. And I was sure that was all really real. And It was terrifying. And I told the resident about it the next day, and he said, "Oh, we can fix that. We'll give you more." And so the next night, when I started to get a little loopy, they gave me more. And about 15 minutes later, my arms went back, my eyes rolled up, I started to hear voices, and I was stuck like this for 6 hours. And the nurse, who had been out about a year, thought I was just a crazy teenager, thought I was just acting the whole way. You can guess what was happening. I was having ocular gyrite crisis, and the chief resident finally got out of the OR in the morning and said, "Oh, he needs some Benadryl." Gave me some Benadryl and I went away, but I had a tremor for a month. I heard voices for the next day. And so, yes, I was quiet, didn't trouble so many people both those nights. I ultimately wrote a paper about that experience in college. I got an A++ from my English teacher, but it was horrifying. And so I always remind them, A, antipsychotics don't do anything for delirium. The literature's clear. And B, all it does is take your hyperactive delirium and puts the patient in a state where you have no idea what they're experiencing.
Hypoactive delirium. That's all you do.
Right.
Yeah.
That's all you do. And yes, if the patient's going to hurt you or hurt the nurse, you got to do what you got to do to keep people safe and to keep the patient safe. But just because they're not talking anymore or calling out doesn't mean they're not suffering tremendously. It was terrifying. You should see my mom had stayed with me that night, and I was trying to explain it to her. She thought I was crazy too. But it was very real.
Yeah, I think this is something we've talked about on the podcast before. Like we had Wes Ellie on, and we have this attitude of as clinicians that like, oh, it's just delirium, but like often delirium is like the most distressing symptom for patients and certainly for their families, right? I mean, they don't understand it. They think, is this person going to be like this forever? I think we do a very bad job of like educating people about what delirium is.
Yeah.
I never really had the adverse delirium until this last hospital stay and ICU stay. The one I had 2 years ago, and I don't know, maybe it's just as I got older. This last one, every night it would come and I would feel like I was being chased by a terrorist. I was sure someone was trying to try to kill me. And I knew for moments that it was not real, but it was so terrifying I couldn't make it go away. And the only thing that made it go away was Precedex. Precedex is a magical drug. I have to say, from my experience with it as a patient, I don't know, Alin, if you received Precedex or what you remember from it, but nothing else made it go away besides Precedex. And of course, they couldn't keep giving that to me because they wanted to get me out of the ICU. But that was really the only relief I got from it. And it was profoundly it was terrifying. And I knew it wasn't real, but it didn't matter. It was awful. I was afraid to shut my eyes.
I've had a couple people tell me that as well, that like there's enough meta awareness that they know that they are experiencing delirium, but that doesn't mean they're not experiencing delirium. And it doesn't make it any less distressing. In some ways, it makes it more distressing because you're like, something is wrong. I know this isn't there, but I'm seeing this thing.
Yeah, it was the worst. I don't remember it ever being so distressing or traumatic as this last ICU stay. And I was much sicker than I'd ever been, in all honesty. I was septic and things. I was much sicker, but still, I was like, God, this is what it's really like. This is that awful thing they're going through. Because when I was a kid, it was like I was in the woods and it was really pleasant, or not pleasant now.
Mm-hmm. So, Paul, you mentioned writing a paper about this, and so in preparing for this conversation, I read a lot of like what doctors have written about as patients, kind of the literature of this, and I found this one systematic review of the literature of doctors as patients, and what I thought was interesting was they found a couple kind of recurring themes. One is this idea of the medical self. This is like this idea that somebody behaves as doctor despite being a patient. They sort of want to stay in that more comfortable role. Another theme that they saw often was the idea of role reversal. This is where, the doctor basically has to embrace that they're not the doctor, they are the patient. And the third was this idea of the wounded healer, which is this idea that the doctor learns from the experience and uses their newfound, often painfully acquired wisdom to make other people's experiences better. I'm curious, both of you, maybe Paul first on this one. Do any of these tropes resonate with your experiences? Do you see? Does any of this feel like a fit?
Yeah, I mean, without doubt, the wounded healer. I'm loath to admit on rounds, but a large part of the care I provide every day is based on my own experience of being a patient. When the patient, I walk in the room in the morning to a trauma patient or a surgery patient, and they're telling me their pain is 10 out of 10, and have their PCA is at 0.2 Q10, whereas my colleagues' first response is, oh, it's always 10 out of 10. Mine is take that PCA to 0.4 QA, right? Because they're in the ICU. There's a nurse watching them all the time. They're not going to stop breathing. Or when I write an opioid order, I'll write a milligram of Dilaudid every 15 minutes because I know the nurse is going to give it. But if she needs to, the patient doesn't have to wait for her to go find the resident to change it, right? And I don't let anybody give Haldol to anyone unless they're going to hurt someone, right? And that is entirely because of the horrible experience I had with it. And I can't tell what patients are going through when they get it. I sedate for procedures that most people wouldn't sedate for. I always use lidocaine to start IVs and A-lines and everything else. I would say much of my practice is based on my experience as a patient, and I feel some obligation to teach it because otherwise all those things that happen to me, and I don't know how you feel this, but otherwise it's too traumatic to even make sense of it. How do I make sense of the fact that this, like you must have felt in a very acute way, that you're about to die and it just happened and everything you've worked for in your life and your family, and in my case, my kids and everything else could just be taken. There's no meaning in that. It's impossible to cope with it. It would cripple me. It would paralyze me. And so what I always take from it is this gives me a chance to take this experience and hopefully make one or two or more patients' lives better. For instance, I see all the ostomy patients inevitably because they're all up on TPN. And the worst thing I hear from them is they always say to me, God, I would rather die than have them give me an ostomy. And I say to them, you're crazy. I've had an ostomy since I was a kid. And they look at me and they're like, there's no way you have an ostomy. And I pull my shirt up and pull my zipper down a little bit. I'm like, see, yeah, I do. And I said, there's nothing you can't do with an ostomy that you couldn't do before. And I said, I've dated and got married and had kids and people like me. And I've never not found anything I couldn't do because of it, because they're all sure everyone's going to hate them and their lives are over. Right. And it's like, those are the best days of my life when I can have a patient look at me and say, oh my God, if you can do it, I can do it. Maybe my life isn't over. Otherwise, the whole thing, and I had no idea you'd been through all those other things too. Otherwise, when those things keep happening, you can't make sense of it. You can't even begin to even think you can deal with it. But in some ways, I could say, I experienced something new today that's never happened, a complicated like the fistula I had. I have a much greater understanding now of how to talk to fistula patients because now I've been on home TPN. So when people tell me, oh my God, I'm never going to be able to do this home TPN, I'm like, yes, you can. I promise you can. They're going to teach you. You're going to do it. And you can exercise and go to the beach and walk the dog and you can still have your TPN on your back. There's people who run marathons. I mean, it's like you get this chance to share with people that are hopeless that there's hope.
Alin, does any of that resonate with you in your story? Curious.
Yeah, absolutely. The wounded healer, the perspective that I have, I'm not a very religious person, but I feel like after all this happened to me, the only way I could justify it was to say, okay, now I'm a physician with these experiences that most physicians don't have. So it's almost like my superpower. And that has helped me, I've had other complications after my transplant and I've been hospitalized quite a few times. And I feel like anytime something happens to me, I take it as like, okay, I can go back to being a physician, but now I have these new experiences that I come to work with every day. And just as an example, I remember one of the times that there was people tell you they'd rather die than have an ostomy. People tell me, they'll be like, I would never get a transplant. Like, are you kidding me? And they don't know that I'm a transplant recipient. So what I started doing, especially when I was in fellowship, was if there was a younger person, specifically like pediatric or 20s, 30s, 40s, who had sudden organ failure needing maybe liver or heart transplant, I called it like any of the attendings knew me and knew that I was open about my story. Can you go talk to this person? And I'd go in and I'd say, I'm not your doctor. I just happen to be someone who has a transplant. And I would ask them reasons like, why are they afraid? Or if they have any questions for me. And I would tell them how I'd be like, it's not easy by any means. Like I've had plenty of issues with my transplant. However, it's, in my opinion, for me, it's better than the alternative. Now, if you really, again, ICU doctor, all for people, wanting to go palliative and wanting specific things done or not done. But I do tell them these. And there was actually one patient who said the most life-saving that was ever done was you talking to me. Just like not even like the ICU stay and all the things that we helped do, we resuscitated him. It was just that talking and him knowing that, hey, there's another 35-year-old who has been through this. so it's really helped me have this, again, justify everything that happened to me, not in like a spiritual way, but it's almost like that's the only way that it keeps me going as a physician, because I know that most physicians don't have this perspective that I have. At the same time, I'm very careful to say that I don't think this is what makes me a good physician. I think you can, but you can be a good physician without having cardiac arrest, I think. But if you're open to hearing these perspectives that I have, if you're open to asking me, what does an A-line feel like? What was the worst thing that happened in the ICU? That's what they can take away from my experience, because I share everything that I can.
Oh my gosh. Yeah, that
was excellent.
Really tremendously well stated, Alin. And I think that's a great perspective that you bring, and something, we may not be able to share a story like yours with our patients, but we can still draw upon our training and our own experiences to sort of level with someone during times like these and try to humanize the experience and try to understand, where is their reluctance coming from? Where are their concerns coming from? And how can we either assuage those concerns or help them explore those concerns to the point where they're like, you know what, I truly don't want to do this, but now I'm deciding it based on not just my trepidation, but an informed decision. I think that's a tremendously powerful approach. I did want to pivot a little bit, because I know Paul had talked about his wife. He's talked about her numerous times, so she just must be amazing. I have to imagine. But again, for your own experience, Alin, as a patient, were there specific folks in your life, friends, family, what have you, that you really had to lean on at times when things were really challenging? And what was that experience like for you, having to seek help from someone else to get you through those challenging times?
I think basically like my parents have probably been the most supportive. They know everything. And, I always feel bad for them too, because I could tell that there's things that I have to explain to them. Like, I'll be like, hey, if this happens to me, this is what you should do. But they have been there for me for everything. I mean, I was living in Philadelphia and New York City. I'm from Los Angeles originally. Both my parents basically moved to Philadelphia after my transplant and helped me out. And all my friends, my current partner, he's been amazing. I haven't had any issues at all in voicing whether or not I need support and whether or not I need help with something. Now, what they'll tell you is that I'm really hard-headed and I never ask for help, but I don't think that's the case. Like my boyfriend will be like, no, she would rather, like, she will say she's fine until like she is not. But
well, I mean, to be fair,
I think that
to be fair, Alin, like your blog does kind of suggest that when I was reading through it. So I kind of have to side with your boyfriend on this one.
I think that I've never felt like honestly, and shout out to Mount Sinai's program, my critical care fellowship. They were the first people that I emailed after I had extubated, when I was first decompensating before I got my heart transplant. And of course,
and by the way, can I just interject here that is like the quintessential thing to do as a resident?
Oh, wait till you hear what I said. Hey, just got extubated. I'm in cardiogenic shock in the ICU, but and I got into your program a couple weeks ago. Would you guys accept me for next year, or do I need to reapply for ERAS if I make it to
Oh my God.
Oh my God. Email, I was like, if I'm alive,
Oh my God.
ERAS application.
LOL.
They were the most supportive of all. I just had to finish my residency. My residency shut down, which is a whole other podcast on its own. So I had to find a new residency, but my fellowship, Dr. Wang and Dr. Orapello, who till this day are amazing. Dr. Wang actually came to visit me when I was recovering from my heart transplant, and they continued to support me. Keep in mind that when I started my fellowship was 2020 in New York City. That was COVID, and I was hyper immunocompromised still. So people ask me how I did it. I'm like, well, if I knew someone was definitely COVID positive, I would try not to intubate them. But instead, my co-resident would, and I would do the HMP, right? So there were little things like that they definitely helped me do as a fellow. But, overall, it was great. And they were so supportive, especially when I had to take time off for specific hospitalizations and those hip replacements and stuff. So it was really nice having that support.
So do they make you do ERAS over again?
No, they actually were they told me later on that they had a meeting about this, and they were like, well, they, I guess they were impressed with me, and they were like, we'll definitely still have her as long as, but we're not going to force her, because people also assumed that I was forced to go back to fellow. I'm like, no, I could have not done it. My thinking was I wanted to at least try. if I tried, at least I wouldn't regret it later. And then, I ended up finishing it. So it was great. But it was amazing having support, not only of my colleagues, my mentors, and then my family, of course.
Yeah, so you guys have both shared so much, so much of what it's like to be vulnerable and afraid and going through the pain of being on the other side of the drape. I'm curious how, Paul, with everything that you went through, how you didn't lose hope along the way.
Yeah, I think, like Alin had said, I have incredible parents too. I mean, my mom and dad, without doubt. I was adopted actually as an infant, and I always say, God, thank the Lord I was given the parents I was. I don't think I'd be here today without them, or I'd be in jail, one of the two. But I really did have incredible parents. My mom spent every day. So I was a patient at University of Chicago. That's in the inner city of Chicago. And ever been to University of Chicago who knows it's in a very bad neighborhood. It's on the south side of Chicago. And my mom would take the train from the south suburbs of Chicago, 40 minutes into the city, and then walk a mile through some of the worst neighborhoods you could imagine by herself every day for 4 months to see me. And then my dad would drive down and pick her up every night. It was a good hour drive from where they lived. And so I had this incredible support, like it sounds like Alin had as well, from my parents. And then later in life, I was lucky enough to marry someone, where my parents, like yours, probably were more passive, and I think I feel an obligation to defend them, and to try to explain to them that it wasn't their fault that I was sick, and they did everything right, even though they feel like they didn't. I think now I'm married to someone who is the most aggressive protector I could ever imagine having. There are so many times when you're that sick that even as like I guess you'd say a senior physician where I am now, I switch into, like you said before, that patient role, and I can't defend myself. I don't. I'm like, there's times you're defenseless, and she's always there. We'd been dating about 9 months when I got sick the first time. And actually, she was the first APP we ever hired in our ICU at University of Colorado. And we didn't tell anybody we were dating for the first 9 months because we knew that they wouldn't let us work together properly because I was sort of semi-supervising her. But it all came out of the bag, of course, when she was at my bedside when I was in the ICU with ischemic gut. And suddenly she wasn't the caregiver anymore, but she was at my bedside as the family. And that was how our relationship sort of came to light. And I never knew someone could be so caring. She spent every night for the next 30 nights sleeping in the hospital, working during the day, and then sleeping next to me every night. And this last hospitalization, when I was in the hospital in the ICU, my dad would spend the day with me. Still, they flew here to be with me. Same, they live in Missouri, St. Louis. And then she would come for night shift and spend every night, and would almost never sleep at night. She'd sleep during the day because she was so afraid I was going to die over the night, or something was going to happen, or something was bad was going to occur, because a couple of nights it did, where I ended up getting rushed back to the OR a couple times with these leaks. And so, but in terms of, I don't know that I would know how to give up. I don't know that I've ever thought there was a choice but to keep going. Right. I don't know that I've ever imagined an option where you didn't. I mean, and I tell my patients, I don't want to see them in the bed at all, because beds kill people, and beds are evil, and all they do is cause blood clots and weakness and death. And I've had to live that, right? And I've always realized that's the things that have gotten me better. I'm out of bed the first day, and like this last time, this massive incision, I was out of bed 12 hours later with my A-line and all my tubes, and I was doing bed squats, off the bed in the ICU still, and it was using bands off the door. And, I don't know any other way. I mean, this is how I've always lived my life. And I guess it's even hard for me. I originally thought I would do GI, and I would go into gastroenterology because I was so attached to IBD and thinking I would want to study that. But I realized there's so many patients that become victims of their diseases, and they can't fight, and they just want to give up. And I don't know how to take care of them sometimes. Because I always say, but you can get better from this, and you can have a life after this, but you just have to do the work. And they said, well, you don't understand what it's like. I can't do the work. And I didn't know how to respond to that. And I realized quickly that I can't take care of them. It was in medical school that I realized that quickly. And it was in the ICU where I felt like I could fight for people. And I started as a kids ICU doctor and kids burn doctor where everybody lives, which was a joy, actually, because it was great to have everyone live, and patients that would fight and do those things. It's clearly there's times where palliative care and fighting isn't the right thing. And that took a long time for me to learn. But I think, and Alina, it sounds like you'd say the same. I don't know any other way. And I've always realized that I always do get better. If I do all the things right and get my nutrition right and start exercising right away and go back to living my life as normally as I can, as quickly as I can, I get better. And I always have. And so I think I just have this unwavering belief that I know I will. And I try to convey that to patients and with varying degrees of luck, honestly. And so I think I don't know any other way but to have.
One thing I've heard both of you say is that, you feel like it's important to share that sort of like light at the end of the tunnel to people who are, in the most acute phases of their illness, and kind of show them what recovery looks like, that it is possible to be functional and do these things again, which I think is really valuable. I wanted to double click on one other point I heard you say there, Paul, which is both of you mentioned the importance of having family with you during illness. I'm curious what your thoughts are about, since COVID, there's been this movement to have much more restricted visitation in ICUs. It used to be more of a 24/7 thing, now a little more constrained. I'm curious what your thoughts are on that.
It's devastating what we did to patients during COVID. I mean, all of us probably saw this. How many people did we watch die alone and suffer alone? It broke my heart. Leslie and I have talked about this a lot, actually, and it was devastating what we did to people in that period. It was interesting. We had a few folks from other universities who were medical providers whose family were hospitalized at Duke. And somehow we found a way to let them in the room in gown and garb, and they would spend all day and nights with their family members, but nobody else got to. And it just made me realize this is absurd what we're doing. And I guess I can speak from experience. When I was hospitalized in Hawaii, they weren't letting people in and my wife couldn't be there. That was the worst hospitalization I've had in 20 years. I ended up getting Reglan for bowel obstruction because they thought somehow that would help. Like, when you're sick enough, you can't make always good decisions. And like, she doesn't let that stuff happen. She would have never let that happen. She was furious to the point where she almost took me out of the hospital and flew me home with my IV and still, because there were things like they misread that I had contrast in a colon that I hadn't had since I was 15. And I mean, they were making pretty significant errors at times that she would have never let happen. And it made me realize, God, I don't know how I get by if she's not there. And I think, how do our patients get by? It was tragic, is all I can say. It's going to choke me up to think about if I start talking about it more. But I think it's pretty tragic. And I think visiting hours should be unlimited in every situation, especially in the ICU.
Yeah, I share that soapbox with you, Paul. I mean, I think people need support 24/7. Why should visiting hours be like 9 to 9? And one of the most effective remedies to delirium is reorientation by a familiar person, right? And so like kicking familiar people out of the hospital at night seems kind of backwards to me.
The antithesis of good care, I think.
Yeah, it's interesting to hear your perspectives, having been in and out of the hospital so many times on all of these different things, Paul. And I'm so grateful that you're able to share that breadth of experience. And then, Alin, you've had such a different experience. I mean, there are similarities, of course, but then it's such a similarly unique perspective. It's its own story that I think is just amazing to me. I think we're very similar in age. So when I hear this, I'm like, oh my gosh, I had like no barriers to me becoming a physician. Like, and this, like, by all accounts, like you could have and in some ways should have died at points during your development into.
It was just pseudo PEA.
Oh, it's not.
My math. It was my
anyway,
math.
I'm grateful for both of you. I did want to ask though, Alin, specifically, we've talked a little bit about your blog, and I've read some of the posts there. I think it's really great. I think anyone who listens to this podcast should take a look and read through it. It's a great chronicle of your journey in medicine, your journey through illness and beyond. I'm curious, kind of two questions here. What motivated your decision to sort of publicize your story in such a vulnerable way, I guess I'll say? And then how did your experience in illness kind of frame your personal and professional goals going forward?
So I'm a millennial. So like I didn't know you can't share, right? Like when people ask me, I'm like, well, of course I'm gonna put it on Instagram and Twitter and but part of the reason when I first started sharing my story was just because I was getting so many texts every day And it was just easier for me to just put everything in one place. After my transplant, they give you a lot of steroids. So at first I was like, I'm manic. Like, am I manic right now? Because I just want to do everything. I was like trying to study for boards, like 2 years before boards in the step down unit after my transplant. But I decided to make this blog. So I started a blog, and initially was to just like put my story out. So I stopped, so I wouldn't have to like tell everybody individually. But then it turned into like a way to like raise awareness about organ donation and do all these great things. And honestly, the best thing that came out of it was the connections that I made through my social media and my blog. Like, a lot of doctors and nurses and healthcare workers would message me and say like, hey, like, I'll never forget, someone once told me like, I went through chemo like as a resident and I never told anybody, because they just like, so it was like so refreshing that I was talking about my story just so out there. And a lot of people would be like, are you sure you want to talk about it? Like, what if you get like employment, issues? And I'm like, I didn't even think that far ahead. Like, I was just like, I never thought it. Like, it was just the way that I was, doing things was to share. And I was like, well, worst comes to worst, I just won't have a job. I don't know. I didn't really like think that far ahead. So it was a really good way for me to not only like express myself, tell my story, but also connect with others who were going through something similar. We ended up making a group called Docs with Transplant. So it's over 70 of us in the group now, who are physicians with actual organ transplants. And like, it's amazing, because I do think we are a different subset of patients as physicians who have also experienced these things. And so I connected with a lot of people through it. And then as far as my career goes, I feel like, because of all the advocacy work that I did, because of how much I shared, like, I ended up getting some really awesome like roles, right? Like, I don't work at the bedside anymore, but I do telemedicine. But it's really awesome because I do that part-time, and then I'm the medical director of California's organ procurement organization. So I'm like all in transplantation and organ donation. I have taken care of transplant recipients. I am a recipient, and now I take care of organ donors. So I've let my story kind of help my career in a way, kind of serendipitously. Like, it wasn't like something I didn't think this would ever happen to me. So it was nothing that was like planned. But with that being said, I guess I'm more like Nick in that I kind of like take things as they come, and I kind of like hope for the best. I'm not someone who likes to like, once you've been in the situation of being in the ICU, and like, I remember having difficulty sleeping because I kept thinking, if I sleep, I might not wake up in the morning. And once you go through, like, everything was taken away from me. And I feel like I've lived life on the edge. And because of that, I almost feel like I don't want to say not neurotic, because I'm sure there are some things that are pretty neurotic, but I'm just kind of like, well, like, we'll see what happens. And I feel like all of that has really helped shape not only my career, but my life in general.
Amazing.
I think it's really inspirational. Yeah, how both of you have taken things that happened to you that could have been just stochastic bad luck things,
Right.
and made them benefit so many other people. I think that's a really wonderful thing, and I think you're both courageous to share your stories as you have. We have a little bit more time, and I was thinking maybe we can end with just a couple like really specific pitfalls and pearls that are like tangible takeaways for listeners, like do's and don'ts from your own experience. If you guys want to just throw out little things that you've learned being on the other side of the drape, and along the way we've mentioned many, and maybe we'd summarize those too.
One of the best things that ever happened, I think, and it probably was better or more psychologically helpful to me than the people I was giving a lecture to, but Wes Ely asked me to give a talk about my patient experience at one of the SCCM events years ago. And Pratik Prabhahar, who's one of the guys at Vanderbilt, nominated me for this award. It's for delirium from the American Delirium Society. And a lecture went with it. And it actually made me sit down and think about what I would say to physicians, what a patient wishes their physician knew. And it was really, I'm really grateful to Wes and Pratik for giving me that opportunity, and for the American Delirium Society for letting me put this together. And these were some of the things that I put at the end. There were these pearls and these tips. And again, we talked about some of them, but one of them clearly I said is all IVs should be started with lidocaine. And that seems simple, but every patient's going to get one. And having been stuck as many as 15 times, even recently as last year for an IV, that's misery. And people should think that through. NG tubes should be used much less than they are. Doctors should never shut the door outside a patient's room when they round to talk about us. I don't ever it's intolerable to do that, and it's torturing to patients. I think sedation should be used more liberally, and it should provide comfort and be looked at every day. I think we undertreat pain now in this era versus what we used to do, but then that has to be done thoughtfully. I think the use of antipsychotics and things that cause confusion and terror should not be done. And so I think sedation should provide comfort, but not terror like a lot of the antipsychotics do. And I think major and minor procedures should have sedation. I think ketamine is an underused drug that all of us should use more. Yeah, I use it almost every day. And then I think opiate and sedative withdrawal should be recognized and treated. I think, people on Precedex too long withdraw from it. It's like withdrawing from clonidine. People on opiates are going to withdraw from them. I don't care who you are. No one's immune. And there's really brilliant ways to treat this that are very simple, and patients don't need to suffer, but they still do all the time. And then, like I said before, I wouldn't prescribe oxycodone to anyone ever, except for people with terminal cancer pain. I think those are the things that are most important. The last thing I would say is, every time you see a patient or do a procedure, imagine that you're the one laying there, or your child or your loved one's laying there, and say, how would I want to be cared for if that was me or my mom or my child? Because to me, patient care starts with caring, and patients are people and not boxes to be checked off a resident's to-do list. Remember, there's a person there that is just like you.
I agree with all that. The other thing that I usually tell people, my colleagues, is be mindful of your blood draws. So like, just because someone's an ICU patient doesn't mean they need everything drawn every day. And then the same thing, I don't use lidocaine before starting IVs, but I at least, I tell the nurses, try once, try twice, but no need to constantly if something you're doing isn't working, just go grab someone else or grab the doc or do ultrasound, just change the method. No need to keep poking. And then another thing I tell people is, at the end of the day, I especially tell healthcare workers this, but what you do really does matter. Right? If it wasn't for people like you guys, I wouldn't be here today. Paul wouldn't be here today. And I think it's important for us, because I do know how burned out a lot of us are. And I think it's important to also see the positives and the impact that you do have on many people's lives that you don't necessarily see outside of the ICU. And it's important to keep that in mind.
Yeah, I would agree. I mean, I can't say how grateful I am to so many nurses and physicians, and like Deb Sudan, who's the surgeon that essentially saved my life over these last few years, and so many surgeons and doctors have done that. There's too many to name, of course, but I agree. And if Nick and Cyrus, you'd let me, there's something that I saw on social media one time that is, I think, one of the most poignant pieces of advice I've ever seen. I wish I could claim it's my own. It's not. I don't know what the source of this is, but it's called Advice from a Patient, and it's just a few sayings that to me I think are the best things I could ever imagine teaching a young physician. And they're really simple, and they go like this. The first is, this may be a normal day at work for you, but it's a big day in my life. The look on your face and the tone of your voice can change my entire view of the world. Remember, I'm not usually this needy or scared. I'm here because I trust you. Help me stay confident. I may look like I'm out of it, but I can hear your conversations. This is the one that means the most to me, but I'm not used to being naked around strangers. Keep that in mind. I'm impatient because I want to get the heck out of here. It's nothing personal. I don't speak your language well. You're going to do what to my what? And this is my favorite one. I may only be here for 4 days, but I'm going to remember you for the rest of my life. You'll forget me tomorrow, but I'll never forget you. And then your patients meet your patients. And I don't know who wrote it, but it's a set of things that have always meant a lot to me, and every one of them has some memory. And so I think it's the tag post on my Twitter feed, on my X feed, if people want to read it.
It's always Twitter to me.
Yeah, me too.
Old habits die hard, right?
All right, Paul. We'll allow it. Thank you. Thank you for that. That's a perfect note to end on. Yeah. Thank you, both of you. That was amazing. I think. Yeah. I learned a lot.
Well, I don't really know how to close out an episode like this other than to thank both Alin and Paul for sharing very personal stories with us. Dr. Gragossian, Dr. Wischmeyer, you guys, I think, typify what it means to be a humanist physician. You've had these experiences, and rather than sort of cowering from them or letting them define you in a negative way, you've drawn power from them. And I think you're doing great things in the world for clinicians and for patients alike. And I hope that our listeners recognize that and appreciate your time and your contributions. We really hope that you guys enjoyed the conversation. Thank you guys so much. It's just really been an honor to talk to you guys.
Thanks for having us.
Thanks for having us, Cyrus and Nick. This is a really
Yeah,
incredible
thanks for joining us. Any particular places that listeners can find you on the interwebs? Any organizations you want to plug? Paul, you're a prolific educator on Twitter /X, Insta, TikTok. You want to tell people where they can find you?
Sure. So my Instagram feed, which I feel like is where I have my best reach, and I love the visual nature of its communication, is my name, Paul Wischmeyer, MD. And if you followed me before, my account actually was hacked and deleted about 2 months ago, with 170,000 followers gone in one day and not able to be recovered, which is pretty devastating. So I have a little different now Instagram name. So if you followed me before, please follow my new page. It was quite an experience to realize you can have everything just blown up in a moment by like that. But that was educational. On Twitter, I'm Paul_Wischmeyer. And on YouTube, I post a lot of my lectures, including some about my patient experience. It's Paul_Wischmeyer, MD. Are the best. I'm also on Threads and a little bit on TikTok, and then on LinkedIn, of course, my name, Paul Wischmeyer. But most of what I post is on Instagram and on X.
And I'm at a change of heart blog, underscored after each word on Instagram. And then I forget what my X one is because I barely go on it anymore. I think it's like AGEM33.
And then, Nick, the last thing I'll plug is our Duke Online Clinical Nutrition Fellowship, which you guys can Google. Anybody can Google that, and we're always looking for people to want to learn more about nutrition and exercise, and that we can educate. It's all online. So we have a new class starting in January. So we just finished, graduated 28 people. So just a few weeks ago.
Fantastic. Thank you.
Yeah.
Well, to our listeners, I hope you enjoyed this conversation as much as we did. That I feel like these kind of episodes are the ones that like just teach me a lot, and I hope you all feel the same. There's more on our website, www.criticalcaretime.com. You can find all the links that we just talked about. You can find sort of summary. While you're there, you can subscribe to our mailing list. You can grab some merch from our brand new merchandise store, or you can leave a comment. And I think that, we read all your comments. We use them to come up with ideas for new episodes. We have a mailbag episode. So please, please, please give us feedback. We love it. We thrive on it. Speaking of feedback, please, please, please give us a 5-star rating on your favorite podcast app. This helps other people find the show, and that means the world to us. So if you can, we love comments. We also love to hear from you. You can tweet or X at us at CritCareTime, or individually at Nick M. Mark or at Askins_Razor. We are also on Instagram, but we are small potatoes on Instagram and Threads. We also have a YouTube channel too, where you can watch us instead of listening to us.
And in keeping with the theme here of saying thanks, we do want to thank our sponsor for season 2, C-Star Medical. We're fortunate and grateful that this episode and all the episodes for this season and last season of Critical Care Time have been sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And then before we go, we want to say thanks to all the members of our team that make this possible, editing out all of our, the stupid things that we say that you never get to hear. Thank our production team over at Podpaste. I'd also like to say big thanks to Kurt Belknap for composing the awesome theme music you're hearing.
And of course, as we've already said, I'll say it again, thanks to our wonderful guests for participating in this episode. It means the world to us. And those 5-star ratings that you give us help put us on the map and help us attract thought leaders like Paul and Alin. Finally, I'll say that the views expressed on our podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real world cases are purely coincidental. Of course, the stories that you heard today are notwithstanding.
They are real stories.
They are real stories. And then finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. Thank you so much from the bottom of my heart, guys. I am and always will be Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thanks, and see you all next time.